So what I'm going to talk to you about is the scale of the problem that we're dealing with. Current solution to that problem and why it is we even need to do this work. So just a little bit of orientating you to anatomy to start with. So very simply, the breast is formed of these lobules, which can be thought of almost like these bunch of grapes at the end of these tubes, and the tubes are breast ducts. And we see abnormal growth and abnormal cells quite frequently. And when they're confined to the structures that I've just described, they're if you like, precancerous change, they're cellular changes that are well on the way to becoming cancer. And as you can see in the bottom here, once they've broken through that structure, that's when we call them cancer. So what's the scale of breast cancer in the UK? Well, it is sadly an extremely common problem. You're talking about 55,000 new breast cancer diagnoses a year. That's about 150 new breast cancers sadly being diagnosed each day. It claims an awful lot of lives as well, sadly. Many of you may have had relatives that have been affected by breast cancer. Although there is some good news in that many more women are surviving breast cancer now than ever before, and 78% of women are surviving 10 years or more. So, very briefly, the surgical options for breast cancer, how could we treat breast cancer with surgery? Well, we have the option of mastectomy, with or without reconstruction, rebuilding the breast mound using a number of different techniques. But as is shown on the screen there, that's really a simple mastectomy. It means removal of the breast, the nipple, and leaving a flat line on the chest there, flat scar. Breast conserving treatment, on the other hand, aims to preserve as much breast tissue as possible. And both of these modalities of surgical treatment, both options, are equally good. There are some patients that, for whatever reason, cannot have breast-conserving surgery, which is beyond the scope of this talk. They unfortunately have to have mastectomy. But we know that, and this won't surprise you, that this option is favoured. Many women would much rather hold on to whatever breast tissue they can. And we know that that leads to a better quality of life. And so we do strive where possible to preserve as much breast tissue as possible, i.e. the breast-conserving surgery route. Okay, so what's the problem with that? Well, the problem with that is illustrated on the screen. And if I had to explain this to you briefly, we aim to obtain clear or negative margins. Hopefully you can see the tumour in the middle of this surgical excised specimen and normal breast tissue either side, all the way around this tumour. Okay? So that's what we're trying to achieve, negative margins. Unfortunately, it can transpire that we cut very, very close to the cancer cells, way too close to the cancer cells. And we call that a positive margin. And when we have a positive margin, we don't know, we cannot be sure, is there any cancer cells left inside the patient in the cavity, in the surface where we've removed the tissue? And it's a flip of a coin. And that risk is, for most patients, far too much risk to accept. And therefore, when faced with this situation, patients undergo reoperative surgery to ensure that all the cancerous cells have been removed. Hopefully everyone's still with me when I'm talking about that. So this looks like a complex graph, but actually I don't really want you to focus on very much other than this bold line that you see at number 20, because what that shows you is the average reoperation rate for the entire UK. This is relatively recent data. 20%, 1 in 5 patients in the United Kingdom are going back for further cancer surgery to ensure the margins are clear. And we personally feel that's unacceptably high. How many women do we think this affects? Well, triennially, we think it's about 11,000 or so women. So it's, again, not small numbers. Again, breast cancer is a very common cancer. breast-conserving therapy is the desired therapy, and so therefore we're likely to see these numbers increase as we get increased numbers of breast cancer diagnoses. So you may be thinking to yourself, and hopefully some of you are, why on earth is this going on? Why do we have such a high reoperative intervention rate? And I'll give you some of the explanations. Certainly some of this is my opinion, some of it is evidence-based, but we're certainly seeing smaller and smaller cancers being diagnosed. Patients don't necessarily have any symptoms. They present through screening. The patient can't feel anything, the surgeon can't feel anything, and what this is showing you on the screen are guide wires into the breast to help me as the breast surgeon guide where I should be, what tissue I should be removing. So that's part of the problem. Even when we can feel inside and feel a palpable lump, a tumour, it's often a little bit more subtle than it may sound to know where the edge of that tumour is. And the surgeon really is using his best 3D perception, or his or her best 3D perception to guide. The other problem is that what we know, if you remove lots of tissue, you may be thinking, why not just remove a very large area of tissue and be safe? Well, unfortunately, that can degrade the cosmetic appearance, which I've told you is not good for quality of life. So some of you will be familiar with this film, one of my favourites, and breast surgery sometimes feels not too dissimilar from this, really somewhat using educated guesswork, best guesswork, which, as you can see, transpires in the majority of the cases that that's fine, but there's a substantial proportion where we are unfortunately wrong. And so why should you care about this? Well, I would say that you should care about this because if you have a positive, or if you have a negative margin, yes, you have a relapse rate, because it's not just necessarily clearing all the cancer out that dictates whether the cancer comes back or not. But if you have a positive margin, as I was saying, cancer cells right at that cut edge, you have a substantially increased rate of relapse in the breast. That probably doesn't surprise you. The cancer can come back that much more frequently if we don't take the cancer out properly. That's going to be no surprise to many of you. The other reason I think you should care about it is because reoperation leads to a huge amount of anxiety and stress for the patient. I just want you to imagine for a scenario having a cancer diagnosis, undergoing a surgical operation, coming back a week later, only to be told that we haven't got all the cancer out. That's really demoralizing. And I can tell you firsthand, as a breast cancer surgeon, it's really demoralizing for the surgeon as well. So it is a problem that we really do need to fix. The other thing is, if you're undergoing more surgery, you're not progressing to the next part of your therapy, which is also important for your outcome. So if you're on the operating table, when you should be having chemotherapy or radiotherapy, you're experiencing significant delays to the other treatment that we know is going to help your cancer treatment. The other thing is that, as I mentioned to you, taking out more tissue is probably not the solution. Reoperating on these patients means move more tissue, you degrade the appearance. This just shows you that on the bottom you're seeing increasing numbers of percentage of breast tissue being removed and how that affects the number of very satisfied women's going down and not very satisfied women's going up. So that's another problem with reoperation, is it degrades the appearance of the result. I think as a nation we should be very concerned about the problem because it's triennially 22 million or so, maybe more, and that's a conservative estimate on the cost of sending these patients back to the operating room. So what are the solutions? Well, on the bottom, you're seeing the possibility of adjusting practices and or just keep removing tissue, which I'll talk about in a second. There are some techniques, these are margin assessment technologies or margin assessment techniques. This means while the patient's still asleep at the first surgery, assess the specimen and determine is it adequate or not. Why not do that while the patient's asleep? That sounds like a good idea, and I'll explain to you briefly the options for that. And then there's newer technologies which Professor Takats will talk to you about in a second. So what about adjusting practices and adjusting definitions? Well, we've seen in the UK and in the US, the margin width, the acceptable distance between the edge of the cancer and the edge of where we've cut come down and down, reduce more and more. Whereas before it was several millimeters, now it's a millimeter. Now it's as long as the tumour is there's no tumour cells on the ink there, well then we think we're clear, that's okay. That's where we're heading. And that's because there isn't any really good evidence to suggest that you need to have a specific margin width. We just know that you need to not have cancer cells at the cut edge of the margin. Unfortunately, reducing that, accepting narrower and narrower margins has not led to a reduction in that problem that we're talking about. It's led to surgeons like myself and colleagues constraining the amount of surgery we do to try and get the best cosmetic appearance, and unfortunately it hasn't transpired that we've reduced the positive margin rate as a result of these changes in definition. This is an interesting study, quite an important one, published in a very good journal, New England Journal of Medicine, where they decided to have a group of patients where they said, don't do any further resection at the time of surgery after you've removed the tumour, and another group of patients where they said, just routinely take more tissue away. And what they noticed was that the positive margin rate, the reoperation rate, came down by 50%. That sounds fabulous. Why not just do that? Why not just take out more tissue? Well, hopefully, by now you would be saying that's probably not such a great idea, because it's going to degrade the quality of the appearance, which is important for quality of life. And we know, in this study, there was a very large volume mismatch. You keep taking out more tissue routinely, you take out a huge amount of volume, and you leave the breast not looking very nice. So what other options are there? Well, there are some margin assessment technologies, such as digital specimen X-ray. That means just put the specimen into a little X-ray machine at the time, and maybe that can tell us by looking width away from the tumour. Unfortunately, as you can see here, the accuracy of that's no better than a flip of a coin, even though actually in the UK we do use that quite a lot. Or you can hold probes up to the tissue like ultrasound, but again, they're not particularly accurate. Or you can send it off to the pathologist to get an answer straight away. And hopefully you can see that these techniques, cytology and frozen section, which is a pathology technique, they seem to be very accurate, right? Almost approaching 90%. You may now be thinking after 10, 15 minutes of talking to you, well, what problem is there then? Just send it off to the pathologist and get your answer while the patient's sleeping. The problem is that most pathology labs do not look like this. They look like that. Okay? So you've got two pathologists who are overworked. They cannot process the volume of surgeries we're doing is just too high to make that tenable. It takes 30, if not 40 minutes, maybe more, so we're all waiting for a result. It costs £500 or so per margin to be analysed, so it's an expensive solution, which means no one uses it. So we have a solution that no one uses. So that moves us on to why not use some of the byproduct of surgery. And in surgery we use electrocautery, which creates heat and creates smoke. Perhaps if we analyse the smoke in real time as we're dissecting, it may tell us about the tissues, and Prof. Takats will tell us more about that. And we do use smoke in everyday life to tell us or give us information, so it's not such a great leap in thinking. Hopefully you've seen that we do have a genuine problem that we need to sort out. We do need a rapid, accurate, reliable technique that provides us with feedback in real time and that allows us to adjust at the time of surgery, at that first surgery, to make sure, as best we can, that we've cleared all the cancer. I'll pass you over to Professor Takats.
Does it work? Great. So I'm Zoltan Takats. I'm professor of analytical chemistry. Here, actually, I work in this building. And I'm coming from the other side. So I'm a mass spectrometrist, or actually my group is building analytical instruments, so machines which are analyzing the composition of various samples. In course of the last 5 to 10 years, we've been mostly focused on analyzing tissues, and actually working a lot with Daniel and other colleagues from surgical side to develop technologies to be able to analyze tissues in vivo and give real-time results. So when it comes to identifying tissues, then some people ask that, okay, what's, I'm not sure if this one is working, but let's see. So some people ask, what's the problem with identifying biological tissues? So, you know, from everyday life that, yeah, you can look at a piece of animal tissue, for instance, and, yeah, it still doesn't work. Anyway, I can just do it from here. So, and you can easily tell that, yeah, where is fat, where is muscle tissue, and so on. So, as long as these are healthy tissues, then there is absolutely no problem. They actually nicely separate from each other, and you can identify them just by looking at them or based on their mechanical properties. I'm not sure if it is entirely visible. Can we actually turn off the light on the front? Can we? Okay, we cannot. Anyway, so the problem comes when we want to identify cancer tissues the same way. Because actually, this picture shows really nicely that there are two focuses of cancer in this piece of tissue. One is here, and the other is here. And you can tell that on the bottom, this is healthy tissue. But as you can see, there is a gradual change, and this is something very specific to cancer. So cancer cells don't grow and stop when they reach the healthy tissue, but actually that's what makes it cancer, that it invades the healthy tissue, so the cancer cells grow into the healthy tissue. And that's why it's not like, okay, this is cancer, this is healthy, but large part of this specimen is actually healthy tissue infiltrated with cancer cells. So it doesn't really work this way, but we can go for a different feature of tissues, which we can still use in this case. And that's that cancer is built of different molecules. I'm not saying that entirely different molecules, but different enough to serve as a basis for identification. So you can imagine it the same way as tissues like buildings. So depending on the function, they are having different building blocks. And if something is built really quickly, and actually cancer grows, unfortunately, really quickly, then it will have necessarily different type of building materials in it as normal tissues, which grow much, much slower in a much, much more considerate way. And we can actually use this feature to identify cancer, and we can actually even use it to find cancer cells in a healthy environment. And actually, as Daniel already described, the point here is to find any kind of cancer infiltration in the healthy tissue matrix. So when we are talking about building blocks in case of cancer, then obviously we are talking about the molecules building up the tissue. And again, as you already heard, surgeons these days are not only using scalpel, actually hardly using scalpel at all, but using various tissue disintegration techniques like electrosurgery. Not only electrosurgery, actually there are plenty of different technologies these days used to cut tissues. The common feature of these instrumental surgical techniques is that they don't mechanically cut like a knife, but they practically blow up the tissue, so efficiently and effectively disintegrate the molecular content of the tissue. And what you can see is smoke, so which is quite a nasty, smelly smoke, and you don't really want to, surgeons don't really want to inhale it. But this smoke is actually, this is made of lots of different molecules, clusters of molecules coming from the tissue. And if we evacuate it and send it into a device which would analyze it, which would perform chemical analysis on these molecules, then we can follow the histological nature of the tissue which is being dissected. So, as I said, what we macroscopically perceive as a surgical smoke, this is actually molecular information, lots of molecules, molecular clusters, and what we really have to do here is analyze these molecules in real time and try to give feedback to the surgeons in real time. So there are plenty of different analytical technologies which can be used to look at molecules. They are commonly known as molecular spectroscopic methods. And one of them is called mass spectrometry, which is actually looking at the weight, the mass of the molecules, and separates the molecules based on their different masses. So generally, in case of mass spectrometry, what we do is we have condensed phase molecules, and we turn them into molecules in the gas phase which have electrical charge. And then when we have gaseous ions, they will all have mass and charge. We separate them based on their mass to charge ratio. If we have a good enough mass spectrometer, it means that in our spectrum, there are different peaks. And the mass spectra are really the easiest things to interpret in life, because the thumb rule is that one peak corresponds to one kind of molecule. So if there are two peaks, then there are two kinds of molecules, and so on and so forth. And it's fairly easy to link the peak to the actual molecule it is denoting. And also the intensity of these peaks is proportional to the concentration of that molecule. So it's very nice and very simple. And what's even better is that the mass analysis takes something on the time scale of milliseconds. So it means that when we introduce these ionized molecules into our mass spectrometer, then we can expect an answer on the millisecond time scale. So even if we do a complex data analysis, we can still give a feedback within a single second. And this is actually something which other spectroscopic methods cannot necessarily do. One more important or interesting thing here is, so this is the general workflow for mass spectrometry. But what we are doing in case of surgery is not taking samples out of the patient, but we are actually using the surgical tissue dissection, tissue cutting technology as an ionization method. So as the surgeon is using the surgical dissection tool, electrosurgical electrode, to cut tissues, is actually very efficiently already performing this first step and turning molecules sitting in the tissue into gas phase ions. And then the only thing we have to do is the really quick mass analysis. So Dan already showed some parts of this video, which is on the iKnife. So in case of iKnife, as we both said, electrosurgery is used. So electric current is used to evaporate tissue. And it's really like a knife, so one can cut the tissues with this. And this technology has been around since the 1920s, so it's almost 100 years old. And in the last 100 years, all surgeons were ionizing molecules, just nobody really realized that this is directly compatible with mass spectrometry. So the only thing which we've done really, roughly like 9 years ago, is modified the handpiece a little bit and added a suction line which actually takes care of transferring these molecular species from the surgical side to a mass spectrometer standing bedside. So these molecular clusters are traveling from the surgical site to the mass spec, of course much, much quicker than on the animation. It takes something around 50 to 100 milliseconds. And then as these large clusters, that's the smoke, enter into the mass spectrometer, we've built a special little device which breaks them up to individual molecules. And as the clusters are broken up to individual molecules, they enter into the mass spectrometer. We separate the ionized from the non-ionized molecules. And then there is a so-called time-of-flight mass analysis happening. So in practically real time, we analyze these things. So with roughly half a second delay compared to the surgical process, we can analyze it, and we can, again, right away subject it to statistical analysis and identify what kind of tissue was being cut at that very moment. So this is how it works, and we hope that this combination, so electrosurgery with mass spectrometry, will change the surgical landscape, and in a few years surgeons don't have to ask for frozen section anymore, but they will have the device in all operating theaters, and instead of waiting half an hour, they only have to wait half a second for the results. So this is how it works. This is really the theory behind. And this video actually shows what happens if you take a tumor ex vivo and cut through it. So this is a breast tumor, and now it's being cut through. So this was just the surrounding healthy tissue, and then the electrode goes into the actual tumor tissue and slowly goes through and then comes to the end. So this is a proof of concept which shows that when we are cutting into the tumor, then practically real time you can see it on the screen of the computer. So this is where we've been like 2-3 years ago, and these days we are actually using the device, especially Daniel is using it for actual surgical interventions. It doesn't take, on the surgical side, it doesn't take too much change, because still standard electrosurgical tool is used. We don't need any additional bits on the patient side. The only difference is that the surgical smoke, which is evacuated through this handpiece, goes into the mass spectrometer, and you can actually see a real-time mass spectrum, and you can also see the almost real-time identification of this spectral information. So this can be directly fed back to the surgical personnel, and this information can potentially direct the entire surgical procedure. So breast cancer was really the first area where we started using this device, but this can be used obviously for practically any kind of cancer surgery. So we have efforts in gynecological cancers, ovarian cancer, debulking, cervical cancer, endometrial cancer. We are also looking at head and neck cancer. We are looking at a number of other areas, including gastrointestinal cancers, so gastric cancer, colorectal cancer. And as it turned out, in case of gastrointestinal cancers, the device as it is actually it makes much more sense to not to use it as a surgical device, but build it into the endoscope and create a device which we can call iEndoscope, along the same lines. And we can actually use the electrosurgical functionality of the endoscopic setup to provide real-time information for the gastroenterology professional. So as you know, endoscopy is used in a number of different settings, so not only gastrointestinal, but in our labs we are mainly focusing on gastrointestinal applications, so gastric and colorectal application. Electrosurgery is often used in endoscopy, so mostly to remove little lesions like polyps in the colon. And in this case, a snare, a metallic snare, is used to electrosurgically dissect this polyp. And the same way electrosurgical smoke is formed. And the only thing we really have to do is collect this smoke from the large intestine and introduce it into the instrument exactly the same way. And we can give real-time or almost real-time information exactly the same way as we are doing for surgery. And how it looks like in real time, in the real life. So you can see that there is a polyp, and the snare is already around the neck of the polyp. So you can see the snare over there. And you can see it turns white at some point, and then the mass spectrum just jumps up there. So you can really see that this was something around half a second time delay. And this way, actually, when the technology is combined with endoscopy, we can use it not only for cancer diagnostics, not only for removal of cancerous or precancerous lesions, but for instance, we have a program where we are looking at inflammatory bowel disease, and we can actually not only tell which areas of the large intestine are affected by the disease, but we can also make a difference between Crohn's disease and colitis ulcerosa, so the two main different types, which is really hard even for histopathology. Or this way, we can not only look at the human tissue, but we can also look at the bacteria living in the large intestine and identify bacteria which would actually, on the long run, cause various chronic diseases, not only cancer, but contribute to obesity, to hypertension, and so on and so forth. So I hope this is really just the beginning of the story, and after the translation to breast cancer surgery, we can put all of these applications into the translational pipeline, and in course of the next 5 to 10 years, this technology will show up in all operating theaters and all endoscopic suites all around the planet for the benefit of the patients. So thank you very much for your kind attention, and as far as I know, we will have the Q&A session on the other side of the hallway. Thank you very much.